welcome everyone to another edition of Medicine 3.0 with Bionic Health. I'm super excited to be here today with Dr. Catherine Isaac to share a little bit about the female hormone module. Super excited to get started.
Excellent, Kelly. I am too. This is a topic that I think is really important, and I'm glad it's a service that we offer to our members.
Yes, definitely a unique aspect that we offer where we can really dive into female health, both in pre, peri, and post-menopause, and I'm sure you'll tell us all about that today. So let's kick it off. Tell us, what is the female hormone module?
Sure, excellent. So the way that Bionic Health members are evaluated through our clinic, we do a baseline evaluation that helps us to understand any particular areas of risk that need further evaluation, or persons have any particular symptoms. So let's say, for example, we have a member who's coming in with perimenopausal symptoms. We're going to recommend the female hormone module as a next step for further evaluation. The module basically is a set of lab tests that we use in addition to the physician consultation to understand what their symptoms are. So the combination of the visit with the physician plus the laboratory evaluation helps us to get a better understanding of what's going on, what might need to be treated, and how. So those lab tests include a certain set of important hormones that we check to better evaluate the person's symptoms.
That's awesome. Can you dive into the definitions? I know we've done a few podcasts in the past on female health, but just for our new audience, can you define what the pre, peri, and post-menopausal groupings are referring to help provide some clarity on who might be a good fit for this module?
Those definitions refer to pre-menopausal, which means when a female is menstruating regularly or has usual periods, or on birth control at that time is also a possibility. But basically, that's the period of time in a female's life when she would be menstruating regularly. Perimenopausal is when the usual cyclic change in your hormones are fluctuating and they're not doing the usual dance that they do throughout the month. And so things can become unpredictable. There can be periods of time when the estrogen levels are surging and periods of time when the estrogen levels are quite low. And this is part of the transitioning into menopause. The definition of menopause is having 12 months of time without a period. So until you've had that extent of time, you're still in the perimenopausal phase. And then 12 months out is menopause. So that's a clinical definition. And then postmenopausal would be any period of time after that last final 12-month period without having a period.
Based on these definitions that you've given us, who do you think best fits this module, or why would someone in these different classes decide to do this module?
Absolutely. So that's a good question. So the first caveat is it's not really useful to do hormone testing when someone is on birth control, because birth control oftentimes is using a source of estrogen that is not estradiol, which is what we're testing for. So it's not the bioidentical hormone. And therefore, if you're on birth control, it's not going to be picking up the levels of the medication that they're on. It will suppress their endogenous estradiol, however, so it can be confusing if you're checking levels. It's not helpful. The other important thing to know is that, as I was mentioning, particularly for women who are premenopausal, you're going to have fluctuations in your hormones throughout the month. So it's important to know when you're testing where you are in your menstrual cycle. So your estradiol level in the follicular phase is going to be quite different than what it would be later in the month. So that's one important thing to recognize. But again, if someone is on birth control, that's not going to be a useful period to be checking these hormone levels. But in the menopausal phase, we would consider checking it if a female has not been getting a period and they're expecting to have a period. So that can be useful for identifying things like hypothyroidism, which can cause irregular periods. It also could be helpful for assessing something called hypothalamic amenorrhea, which is when that person is not receiving signals from their brain to start having their usual menstrual cycle. And that could be due to things like excessive exercise, malnutrition, stress. So I would say that would be one of the more common reasons in a premenopausal female to be doing an assessment like the female hormone module. Other times it would be important in a premenopausal person would be for evaluating for PCOS, which is polycystic ovarian syndrome. People with PCOS can have irregular periods or absent periods. They can have what's called hirsutism, which is excessive body or facial hair. They can have acne. So sometimes they can go for a while without being recognized. And it's important to recognize because it impacts fertility. It also can increase insulin resistance. And with their irregular periods, that can even be a risk factor for uterine cancer because they're not shedding their uterine lining as quickly, although that's less common. So that would be another good group of people to test for. And then certainly in the perimenopausal period, it can be helpful to understand what's going on and help to make the diagnosis. So as I was mentioning, hormone levels can be all over the place, but if a perimenopausal person has an elevated FSH, then that would help to be indicative of perimenopause or menopause. Now remember, the diagnosis is 12 months without a period. So even if a person has a high FSH, the technical clinical definition is having missed the period, but that certainly can be quite clear if their FSH level is high. So that's something that we can identify there. And similarly, in the perimenopausal patient, it can be quite confusing because sometimes a perimenopausal person is not having necessarily irregular periods, or they're not necessarily skipping periods, especially earlier in the perimenopausal phase. So during that time, they might be having more frequent periods or having heavier bleeding, and it can be quite confusing. The interesting thing about perimenopause is that it's a time which can extend a period of 4 to 5 years. So particularly when symptoms first start, periods again might be quite regular, but the person is having other symptoms that are indicative of perimenopause, such as hot flashes, difficulty sleeping, joint aches and pains, mood irritability, difficulty concentrating. So there's a whole slew of symptoms that are quite nonspecific and can be very disruptive to a person's quality of life, especially when you don't know what's causing it. So we don't have perfect testing just yet to be able to say, like in the early perimenopausal phase, to say, oh, this is certainly perimenopause. This is what we want to do to think about how to address your symptoms. So we don't have that just yet, but certainly doing some kind of intermittent checking of your labs can be helpful in terms of trying to determine if that is the accurate diagnosis.
Based on all this testing and figuring out either if someone's perimenopause or even postmenopausal, what is the bionic approach to treatment for these groups? Obviously, it's very individualized, but in general, what decisions are you trying to make based on this data that you're collecting?
Absolutely. So for perimenopausal and menopausal patients, what we're trying to do is determine if whether or not that person would be an appropriate candidate for treatment, and is it going to address the symptoms that are that they're concerned about. So that's important. So we don't just use menopause hormone therapy to treat sort of preventatively or proactively. We like to listen to the story and take the whole story into account when we're thinking about treatment. And that's because anytime you're using treatment, you're thinking about the risks and benefits of that treatment. So there are some FDA indications specifically for menopause hormone replacement or menopause hormone therapy, rather. And those indications are moderate to severe hot flashes. So, the person is having multiple hot flashes during the day, or maybe multiple hot flashes at night, and they're waking them up from sleep. So you can be waking up 3 to 4 times, soaking through your clothes. That definitely is an indication for treatment. Another indication is prevention of osteoporosis in patients who are at increased risk. So people with a BMI less than 20 or a weight of under 127 pounds are considered to be at increased risk. So something to think about. People who are on chronic steroids for a variety of reasons, whether they have asthma history or if they have an autoimmune disorder, that can increase their risk because of this steroid exposure. People who are smokers at increased risk for osteoporosis. So trying to understand that person's history, if they have a family history of someone who's had a hip fracture, things like that can be important when we're thinking about whether or not this would be beneficial for the patient. And then other people who are, definitely would be indications for treatment with people who have had early onset menopause, and that can be called premature ovarian insufficiency, which basically means a person who has entered menopause before age 40. And for them, it's an indication because of the long period of time that's expected that they're going to be sort of without estrogen in their lifetime. The typical age for menopause is age 51 in the United States, but it can vary anywhere between age 40 to age 57. So there are a subset of people who do experience menopause even before that typical range. And then it's difficult because, you may not fall into the category of premature ovarian insufficiency, but there are 1% of females who go through menopause at age 40. So they're kind of right on that cusp. And again, thinking about them and that long period of time of estrogen deficiency would be important. And then also another indication for treatment is genitourinary symptoms of menopause, which are the vaginal symptoms that occur due to vulvovaginal atrophy, which is a fancy way of saying that the tissues of the vulva and the vagina are thinning. They're not getting enough blood flow or similar blood flow as they used to. So they can become thinner, drier. People can have bladder pain. They can have urinary frequency or urgency, meaning feeling that sensation of having to go to the bathroom quickly or more frequently. And also eventually can also have increased frequency of urinary tract infections, so actual bacterial infections. And systemic therapy is an indication, though certainly the first line, if someone was just experiencing those symptoms alone, would be to do local topical vaginal estrogen through like a cream.
What are some of the pros to hormone replacement therapy that someone might experience?
Absolutely. So first and foremost, it would be relief of the symptoms associated with menopause. So as I mentioned, people can have significant hot flashes that are disruptive throughout their day, which could be rather difficult. They can be experiencing bladder pain, pressure, pelvic discomfort, urinary frequency, which could be waking them up several times at night or causing them to go to the bathroom frequently throughout the day, which can be quite disruptive and uncomfortable. They can have what's called dyspareunia, which is painful intercourse, which can be very disruptive to intimacy for that person and, cause them to not engage in intercourse because of pain that's associated. So they can have improvements in dryness, they can have improvements in comfort, etc. And then other benefits, as I mentioned, could be bone health. And it's a very interesting process because when we think of our bone, we think that this is something that, we grew into through our adolescence, into our adulthood, and then our bones are just staying stable the way they were at that time. And that's not actually the fact. The fact is that our bones are dynamic, just like our skin. So we're constantly growing new bone, building bone, and we're also breaking down old bone. And when a person is in the premenopausal phase of life, this dynamic process continues where you have bone growth and regression, and it's in a balanced manner. But when a person enters into perimenopause and menopause, they actually go into a phase where there's promotion of bone loss, but not as much bone growth. So it's no longer balanced, and they can actually lose quite a bit of bone, particularly in the perimenopausal period, although it continues throughout menopause. So one of the other benefits would be, particularly if they're starting hormone therapy during that time, would be to slow down the bone loss that's associated with estrogen withdrawal.
Are there any lifestyle changes or recommendations you would make to people that are doing hormonal replacement therapy?
Well, I would say there's one thing to know, which some people may be aware of already, is that oftentimes people can gain weight during the perimenopausal menopause period. And in conjunction with these changes in hormones, you can have a shift in body composition where you have a greater amount of weight carried around the waist. Average amount of weight gain can be between 4 to 8 pounds. That can be quite distressing to people, especially when they feel that they haven't made any particularly changes in their diet or lifestyle, but they notice weight gain. So, in general, during that part or phase of life, it's important for that person to start maybe being a bit more thoughtful about how they're eating and what they're eating and the quality of their food. So, shifting away from the things that we would typically recommend, meaning shifting away from eating saturated fats, simple carbohydrates, drinking sugar sweetened beverages, high fructose corn syrup, etc., things like that. But even if someone is on hormone replacement therapy, and I keep flipping between MHT and HRT, menopause hormone therapy and hormone replacement therapy, they mean the same thing. They're just shifting toward using MHT now instead of HRT. But even for someone who is taking hormone therapy, it doesn't necessarily mean that it's going to produce weight loss when started on treatment. But there is some data to suggest that it can prevent the weight gain that does happen. So it's kind of an uncertain outcome that people can have when started on treatment. It doesn't necessarily mean, oh, okay, I'm definitely going to lose weight. I'm going to lose it exactly in this area that I don't want to have it in. So there's no guarantee with that. But just in general, I think, and you can talk a bit about this as well, I imagine, Kelly, it's important to think about the types of exercise that you're doing because during the perimenopausal and postmenopausal period of life, that person is more at risk for, as I mentioned, bone loss and also muscle loss. And it can be difficult for uh, building muscle at that time. So the types of lifestyle things that you want to be doing, you're thinking about building muscle or maintaining muscle, eating properly to fuel your muscle building, and also incorporating exercises that target the visceral fat that we don't want you to accumulate. And that's the fat that's in your abdomen, in and around your organs.
Absolutely. Prioritizing things like high intensity interval training is a great way to do that. And even considering working with a strength coach or someone that can help guide you through safe muscle building programs that are going to be progressively overloading so that you're not just doing like the lower weight, higher rep. We've seen that heavier strength training can be really effective, not just for muscle building, but also for building this bone density that we want to maintain as much as possible, in addition to things like plyometrics, so basically jumping around. But having someone that can help support that can be very beneficial to a lot of people.
I think that's super important. I'm glad you're emphasizing that because, while we do get many members here who have a background in fitness or have been, athletes in their lifetime, we also have a number of people who are new to this. And all of a sudden, it's kind of like, well, I'm entering into this different phase of life. And now I have to start doing a certain type of exercise that I've never, ever done before. And kind of like with New Year's resolutions in general, people set a resolution and they go at it really hard. Like, I'm going to start walking, 15,000 steps a day, and you've been walking 3,000 steps. That's not a great plan. And we certainly don't encourage people to kind of go 100% out of the gate.
Mm-hmm.
We want our members to learn how to live a life of fitness that works for them and is not going to promote injury. So even if your brain is telling you, I want to be able to run, this 5K in 20 minutes and you've never ran before, just because your mind is ready to get to it, it doesn't mean that your muscles and your body is prepared as of yet. And so you have to be thoughtful about escalating your level of activity. And I mean, it was true for me as well, starting at Bionic and adding in strength training. I'm a perfect example, had not been doing any weightlifting whatsoever. My major activity before starting here was walking, and started to get into strength training, doing light weights even. but it began to aggravate as I was doing heavier weight lifting in my upper body. It started to aggravate neck pain, shoulder pain, and I was having some symptoms that made it difficult to continue. So I'm actually doing physical therapy now, as you know. And I'm happy with that because my goal is to get stronger and also to be like functionally well. I don't want to be just pushing to hit some kind of number. It doesn't really make sense. I want to be feeling well as I'm building my strength. So that's a really important message that I'm glad we're reinforcing for people today is that yes, you'll have goals and you want to achieve them, but it's going to take time. It's going to be gradual. Body recomposition is gradual. Muscle building is gradual. And you're going to have to expect that there may be times where you even need to back off in some of these goals. And that's okay. That's not a total setback or a total reversal of your efforts. It's just maybe a pause or a slowing down until you kind of build up your strength and level of function in order to move forward.
Absolutely. Slow progressions are going to be what's impactful. And even if you can quickly reach a number, if it's not sustainable, there's not really a true reason to be forcing its way. It comes with time, and that can be very frustrating, especially for body recomposition. It can take up to 6 months or longer, depending on where you're at and where you're trying to go. Same with strength. Initially, people get really excited because they'll see adaptations really quickly because it's all neurological when you're a beginner, but the actual process of building those proteins in your body takes a much longer time. And even if you've made progress, there's tends to be a dip in performance because you have to kind of break it down to build it up back stronger and higher. And people get frustrated by that dip. And instead of giving yourself a little bit of a deload or a rest, we keep pushing and pushing, but we're pushing lower and lower, not like giving our body time to super compensate to get above where we were. So the patience is the frustrating part, but it's also the key.
Yeah, absolutely.
Yeah. So we talked a lot about the benefits of hormonal replacement therapy. Are there any negatives or things that people should be aware of that maybe aren't as commonly mentioned or talked about?
Yeah, definitely. I think just we could even cover some of the basics. So, the data tells us that there may be an optimal time to implement um, menopause hormone therapy. So, this is important because as there have been a resurgence of interest in treatment in the last couple of years, there are a lot of people coming forward who are postmenopausal and could be years out from menopause onset. And they're wondering if menopause hormone therapy is right for them. And so as of today, our best understanding is that it's probably best to implement hormone therapy within 10 years of menopause. So during either the perimenopause period or up to 10 years after your last period. And the thought with that is that if you implement treatment later on, where it's beyond 10 years out or after age 60, then that person is not necessarily seeing the benefits that they would have received earlier in time. And secondly, that it has the potential to increase cardiovascular events like stroke, again, when it's delayed for a good, over a decade before implementing treatment. So that's something that's quite important to discuss with people when they're interested. So they can best understand risks and benefits of treatment. Secondly, there are different treatment strategies, and with different treatment strategies, there are different risks associated. But in general, at Bionic, we like to use transdermal estradiol, which is a patch that you would wear to deliver estrogen. The reason is that there's an increased risk of clotting associated with oral estrogens. So blood clotting is a concern anytime you're using hormonal therapy, even when a person is on oral contraceptives, that's oral birth control, that is a known risk and side effect. So if a person has increased risk of clotting for any particular reason or has a history of blood clots, then that certainly would be a contraindication to using therapy. There's also been a lot of information about the potential increased risk of breast cancer, and that is kind of unclear whether or not that is a significant increase in risk. And some people argue that the risk is quite small and it's less than if a person were to have 2 alcoholic beverages a day. So it's kind of interesting when you're weighing the risk benefit of things. But certainly if a person has a increased lifetime risk of breast cancer or personal history of breast cancer, then that would be something to discuss, thoroughly with their physician before implementing treatment. And if it was implemented, it might be something that they would do over a finite period of time, just when, let's say, symptoms were pretty severe. So, so there's a variety of reasons why we want to best understand a person's history and risk profile before implementing treatment. And there are some side effects associated with treatment as well. So typically when you're doing hormone therapy, you're prescribing estradiol, estrogen, and progesterone. And the reason that we do both is that estrogen stimulates the uterine lining to grow. If you're giving unopposed estrogen, then that uterine lining grows and it increases that person's risk for uterine cancer. So we learned a number of years ago that it's quite important to also be administering progesterone in some form in order to prevent thickening of the uterine lining. Now, if a person has had a full and complete total hysterectomy, that's not necessary because they don't have a uterus. They can just be prescribed estrogen alone. But if they do have their uterus intact or even partially intact, then progesterone is recommended. And you can deliver progesterone in a couple of different ways. The most localized way would be through a progesterone-coated IUD that is inserted into the uterus. And so for that person, they could do something like transdermal estrogen and then have progesterone-coated IUD, which would prevent stimulation of their uterine lining. But for many people, we do oral progesterone, oral bioidentical progesterone, and that has a couple of different benefits, which is that it can certainly help with the sleep-associated symptoms, which are very disruptive. And I can say personally, because I used to sleep like a rock, and then during perimenopause, like the smallest amount of light would wake me up out of sleep. But progesterone can be quite helpful. However, not everyone can tolerate progesterone, so that's something to be aware of. Some people can have disruption to their mood and feel more mood irritability and depression when on progesterone. So it's important to educate our members about those side effects so that if they arise, that they can recognize them and say, oh, this is probably due to the medication that I'm taking, and not necessarily start thinking about, is there something else going on as well? So again, that's not an absolute contraindication to taking the medication, but it is something important to be aware of. And the last thing I'll say about that is there are other strategies for management if that occurs. So there are other medications that are not progesterone that we can use that can help to prevent the growth of the uterine lining, but have less of those mood symptoms.
Awesome. That's super helpful for people just knowing up front what to keep, kind of know what your baseline is and where things might be impacted, and if there's other tools that we can utilize.
Okay.
To wrap up, I just wanted to see if you had any closing comments that you wanted to share with our listeners about the female hormone module.
Yeah, there's a lot of information to learn and understand about the female body, especially as it's going through transitions through the period of life. And that can bring a lot of questions for folks. So, here at Bionic, our job is to best understand how you're doing, what are your symptoms, and to then determine if doing the female hormone module would be right for you. That is what our goal is. So we don't just blanket recommend that everybody do a whole slew of unnecessary testing. We like to be quite targeted. And that's why we always start off with the baseline evaluation to better understand a person's symptoms. And, even if a person does do the female hormone module, it doesn't necessarily mean that we're going to be recommending therapy. It means that we're needing more information. And we want to make sure that there are not other things that are going on as well that could be causing symptoms, such as I mentioned, something like this could be related to hypothyroidism, and that's why you're feeling lethargic, and maybe why your mood is down and you're feeling sluggish and you've noticed some weight gain. So again, it's important to be thoughtful in decision making and not just kind of make assumptions about, oh, I definitely need to be on hormones. I've heard about it. I've seen it on social media, and that's what is right for me. Every decision always needs to be thought out well.
Amazing. Dr. Isaac, thank you so much for your time and insights on this module. I hope that everyone learned a little bit today and can carry that on throughout their bionic journey. And if you haven't joined yet, we hope to see you soon. And thank you again for your time.
Absolutely. Thank you, Kelly.
Thank you for listening to another episode of Medicine 3.0. We make this podcast so that you know where to turn for good information on keeping you and your loved ones healthy. Feel free to check us out at bionichealth.com, where we can help you live a longer, happier life.